Hello, everyone. Thank you for joining. Uh, we will wait for for more couple of minutes and then we will start the session. I hope I'm audible to all of you. If yes, can you please put that in the chat box or just react? Thank you, Srinidhi, for the confirmation. Guys, let's keep this an interactive session. Okay. So before the speaker joins, can I know where are you all from? Let's start from Srinidhi itself. Srinidhi, where are you from? Where are you joining us from? Do I have such a shy audience? You guys are all USMD aspirants and you guys are so shy. Oh, nice. Srinidhi is from Bangalore. What about others? Don't worry, we are not coming to your home. So I feel like only Srinidhi is active in the okay. Thank you guys for your introduction. Thank you so much. So we have our speakers here. So I hope you all enjoy the session. Abhishek sir, over to you now.
Thank you so much, Kanika, for your assistance. And good evening, students. My name is Abhishek Paudankar, MD from Kaplan Logic West, India. And for the last close to 2 decades, I've been helping the Indian medical students and graduates to get a successful residency of their choice in the US, including the tough ones like the surgical branches. But then today I thought, like, many students have taken guidance from me so far. So today we thought, we should, get some more experienced guest, from the US who will be the first-hand information for all of you who can help you with all the questions and queries. So the format of the session today is going to be where I would be introducing our guest speaker, and then what we've done is in the recent past we have collected some questions from the students. We have also formulated our own questions on behalf of the students because we know what's exactly cooking in the students' mind, what are the most frequently asked questions. So we've already anticipated those, and we've collated some questions for our guest. And then additionally, you guys, when you filled in the registration form, you also had some questions, so which were really interesting and helpful. We have certainly shortlisted them, which we are going to put forth to our program director today. However, in case those questions which aren't being asked, a couple of things here for you guys. One is those questions were too basic for us to utilize his time answering those questions. And secondly, if you think your question is not being answered, my colleague will, just help you over this call. Maybe in the chat box, she can just, help you with the email IDs and some phone numbers. If you have any questions, you feel your questions aren't being asked, you could feel free to reach out to us, and I will personally ensure that I answer all your questions. All right, so let's begin with the session. First of all, I'd like to introduce our guest speaker. Our guest speaker today is Dr. Indrail Mukherjee, and he's a program director of Advanced GI Surgery Fellowship and Assistant Professor of Surgery at Northwell Health, New York, and the board certified academic surgeon. With extensive experience in residency selection, surgical education, and mentorship, he is deeply committed to guiding aspiring physicians, passionate about innovation, leadership, and diversity. He actively supports IMGs in navigating to the US match process with a strong academic and research background. He has also contributed to multiple surgical publications and continues to foster career development in competitive residency pathways. Welcome, Dr. Mukherjee.
Thank you, Abhishek, for having me here. And thank you for so many students, medical residents, or aspirant residents. Ask me any questions. Okay, this is an informal session, and I would like to share my failures and successes with you.
Great. I'm pretty sure, we started off with, informing students that we are going to have this set. So many surgery related questions started pouring in, and as I said, we've certainly shortlisted some, handful of questions which are really worth discussing on this open platform. So first of all, to begin with, Dr. Mukherjee, I'd like to ask you, could you please share your perspective on the current competitiveness of the residency match process? We'd just like to know from you.
So I think the competition is quite strong. Is it easier than before? In pure numbers wise, probably not. But I do think with guidance, it is easier to crack today than 20 or 40 years ago. I know there's a lot of changes happens in the world, but at the end, people do need doctors, and depending on what you want to do and how much effort you want to put it in, um, I think all of these problems can be solved.
Yeah, absolutely. I completely agree. Understanding the current competitiveness. So, you being a program director, what are the key factors that you personally consider while evaluating an applicant's profile?
To not to make it too silly, we want normal human beings.
Mhm.
Okay, physicians are in a very unique role. We are nerdy scientists, but we also interact with patients. We can't be either one of them. We have to be both of them. So obviously, we need smart people, and anybody who has graduated from a medical school is smart. So now we don't need super smart people. We're not going to make Nobel laureates every year. So we want to find people who are normal, who can take that science and apply it to patients. Again, residency is very tough. Any part of the world, any kind of residency, especially surgical residency, where you have to manage inpatient, outpatient, and a procedure. That's an extra component to our residency program. So to make it simpler, I would suggest that we are not looking for superstars. We are looking for above average, dependable, and nice people.
Right. Since you mentioned about the, surgical residency, so how do you weigh the USMLE scores in comparison to the other aspects such as clinical experience, research, or something? Where does the USMLE score stand when a program director is usually shortlisting the candidates?
So again, all program directors for fellowship, residency, or even to for entrance for medical schools, right? They're all trying to figure out this thing. How does a complete package look like? And when they are getting thousands of applicants, how to take the top cream and the ones that is a good match. One of the easiest thing to standardize is USMLE. Rural or urban American gets it. An American citizen who is going to medical school in an international college gets it. And non-American citizen going to an international medical school in some part of the world also takes it. So that's the basic step. Okay. So that is making sure that you are a safe doctor, you are above average smart, and you do have to get good scores. If you're getting average scores, why would any program want you if you're just making average, especially if you have certain other disadvantages, which a lot of international medical graduates have? The biggest barrier is cultural barrier, right? We have to relate the science to the community. I work in a hospital which has the name of the community in it. Okay. But I always say my contract is not with the hospital. My contract is with the community. So we are looking for these bright people who can take that good scores or their marks and apply it do their daily practice to serve the community. I usually say there's a care model, so clinically competent, which is which can be surrogated to your USMLE scores, some administrative or leadership skills, research skills, like can you actually find out the answer to the problems today, or are you dependent on other scientists? Education, can you teach the next generation of doctors? Okay. And if you are in a surgical skill set kind of residency, show that you have done something in the past. So USMLE scores are the most important, but not the most dominant, not the only player. It's the
Certainly.
dominant
I
player,
mean,
but not the only player.
yeah, I mean, you mean it's a mix of all, wherein USMLE plays a vital role, but it's a package. It's a mix of research, publication, clinical rotations, and of course the USMLE scores. Now, since we're talking about the USMLEs, I wanted to ask you, doctor, uh, when students often they come and visit me, take my advice and guidance, I always tell them, like, start your USMLE preparation as early as first years and second years, and ensure that you give your the first step at the earliest, so that leaves you with ample room for preparing for your step 2 CK research publications, and there are several other things that do you also agree with me, or you have a different opinion on this?
No, I think things should be done quicker, faster, as early as possible. Means if you want to learn from the Silicon Valley entrepreneurship world, fail fast, fail many times, but don't persevere on it for too long. I think step one should be given right after first 2 years of medical school.
Right, right. So students, here's a takeaway. Now it's like, a confirmed thing that take your USMLEs at early as you can, because once you're done with that, a major barrier where you're supposed to score and prove yourself. Once that is like done, then rest of you have ample things for rest of it. So are there any common mistakes or red flags that applicants should be mindful of while preparing for these applications?
Means again, pass on first attempt. If not, have a very good reason why you could not pass on first attempt. Get good scores. That
Mhm.
is the, I think, the bare minimum. Um, Again, I know of people who have failed the USMLE scores and gone on to become great physicians, surgeons, okay, or their board exams. So scores does not matter a lot, but it is very important. So yes, we are saying to give it early, but don't give it without being prepared.
Right. Now, there are two questions. Rather than taking time, I'd like to club both of them together. How important is the USE and the research and the publications in the entire journey of an IMG, non-US IMG residency?
So I'll break up USC and research into two different components. USC is a very vague term. Okay,
Hmm.
it is basically trying to gauge whether you can interact with the American civilization.
Hmm.
Okay, if you can't speak English, if you cannot speak in the tone, in the mannerism that the patient can understand, okay, then you will not be a successful resident. Okay, so USC is not required for any residency program, but USC is required to prove to the uh, program director that, hey, you have interacted with American people, you have related to them, you can talk to them, you can convince them to take 45 milligrams of this dose versus 90 milligrams of that dose, or how to tackle social issues. So I think an observership is fine. Don't spend thousands and thousands of dollars on US clinical experience. Don't extend your medical school. Don't empty your parents' bank account to get US clinical experience. But do it so that you know what America is like, and your program director can evaluate you that, okay, you have interacted with other Americans in a patient-doctor relationship kind of way. So it's important, but it's not that important. One thing is that with the USC, you are going through multiple different programs. So you are meeting a lot more program directors. So you learn how to interact with them, and one of them can be your leads to become a letter writer, and hopefully they can actually give you an interview and you can prove yourself there. So I think doing 3 or 4 rotations, either as an observer or a US or a clerkship, I think it's important to make those human connections so that you can impress them.
Right. But
What?
again, having that hands-on, I'm pretty sure it would add a little bit more value than what an observership would do, right?
Yeah, so again, observership have a negative connotation, like you are just passively going through it. But even if you get again, the big shots physicians will not have an observer, right? They will usually have a clinic, a fellow rotating with them, a resident rotating with them, if not a student from a prestigious college rotating with them, right? But lots of times you have international observers. Means I have had 40-year-old trained surgeons from other from Europe and Middle East who come and observe us, but they are not allowed to touch the patient. They're not allowed to scrub with the patient. They're, but again, if I get an IMG who's a second year, third year medical students, they will not be talking to patients, even though officially they're allowed to, but they can scrub in and watch. So we know that as a physician that USCE and observership is not much of a difference. But if you get a clerkship rotation in your med school, USC is going to be beneficial to make that connections, and probably you'll have a much more meaningful interaction with patients and physicians. So try for USCE, but don't kill for it.
Right. And you were about to, add the research part in
Research.
the second question. Yeah.
So not to discourage people on either extremes. Okay, research is important, but research is not important if you for most of the residency program. Okay, most of the residency programs are community hospitals. Okay, some of them are community which are affiliated with universities. Very few residency programs are purely academic program. And I don't think 95% of the IMGs are getting interviews there. And even if they get it, it is because they have had some other relationship with those institutions. So if you're writing first authorship with detailed papers and all those things, getting into a community hospital, the program director will say, like, I don't think that guy is going to be happy at my institution. He should be applying for Harvard and Yale and Mayo Clinic. Okay, so if you are writing 40 papers, you should go a PhD route, do become a research associate, and then go into one of those big Yale Harvard programs. Again, if you have not written anything in life, if you have no publications, no abstracts, there is no way I can gauge you that you can read a paper. I can tell you 90% of the medical schools in the world, including America, the medical students are just taught how to diagnose fever and how to give antibiotics. They are not taught critical thinking. But in day-to-day activities, we are doing critical thinking. Okay, I write 30, 40 abstracts a year. Okay. Um, and we need residents, students who want to do it. Otherwise, we are just like working on the spinal reflex. We don't want the next generation of doctors to be like that. To summarize, do some research. Don't go crazy unless you want to become a PhD, MD, PhD kind of scientist. But don't think that you are just because you have 270 scores, you don't have to write any abstracts. So for most people, stay in the middle ground. If you have to put an effort to do abstracts so that you can go to conferences where your prospective program directors go. Okay. There's no point of applying to USMLE and going to an Australian conference. It's great on your CV. If it's sponsored, do it. But try to come to an American surgical conference, which is not very nuanced. You're applying for general surgery and you're going to a neurosurgery conference or a maxillofacial conference. It's good, but not great. Come to American College of Surgeons or some of the other major conferences, interact. So many people ask me, talk to me. They say, like, hey, I got from a prelim to categorical. This is one of my friends. He's going to do research where I was a researcher before. And I see so many, not just Indians, South Americans, Europeans who were in a research lab now matched into a conference helping the juniors get into research lab. All these relationships happens in those conferences for faculty and even for junior people.
Right. Now, and again, for those students who could be like graduates or even in the currently in the medical school, if you haven't started with research, as rightly mentioned, let's not catch hold of the extremes. Either I have no research at all and I don't know what a research is all about, or I've done like 10 and 12, which is like too much on your profile. So just try to keep it balanced, say about 3 to 4, maximum 5 research and publications. I guess that should be it. Otherwise, program directors, usually what I've come across is program directors usually don't treat you as a clinician, but they treat you as a research professional, and then possibly you may not be the best fit for them. So considering that, even I would like to advise and like have a similar say what Dr. Mukherjee said, that let's try to balance it out. And for those who are looking forward for research opportunities, you can just get in touch with our colleagues out there. Our group of faculty members will also help you in doing the research publication, right from suggesting a topic till the manuscript followed by publications. So I have a couple of questions more here, and since most of the questions right now, even parallelly in live, they are flooding in, which are more to talk about the red flags. So can we speak a little bit more about red flags such as attempts, gaps, low scores? Because so many questions live that I'm reading right now parallelly are talking about red flags, which includes attempts, low scores, gaps, year of graduation. So do you have
So,
any
so I use the analogy of like the matrimonial websites, right? Like if you see in India, all the newspapers have matrimonial websites or papers. And yes, if you have one red flag, you can compensate with the other. But think about a residency program which is taking 4 residents, okay, and getting a 1,500 applicants. They won't take the effort to go through the red flags and say if somebody can cover it. Okay. Uh, ERAS, the software that people used to apply and people used to select, have filters. And some filters are first attempt, or some filters are scores, some filters are region based, right? Um, and there are some program directors who would want to take those diamond in the rough with a red flag. They will go through a fine-tooth comb to go through the CV and figure out what it is. And whereas some program directors will just take 272 and up first attempt from only US trained physicians, US trained doctors. So it has to be a match. Again, you don't want, if somebody has failed step one, but on the step again on the repeat got a 270, okay, and has 3, 4 red flags but compensated. You don't want to land up in that program who does not take you, because that's going to be a very bad marriage for the next 5 years. That is where people get kicked out of the program, lawsuits happen that he didn't like me because of my race or gender or this and that, because it wasn't a good match. So there are there is a program for you. You just have to find it.
right? And recently, a lot of IMGs from India, Pakistan, and Southeast Asia personally got in touch with me asking that, sir, I had 8 interviews, 11 interviews, but unfortunately, I matched. Few of the students were applying this year for the second cycle, and despite that, they didn't match. I'm pretty sure there must be something wrong somewhere. Otherwise, I don't think a person can have that a bad luck. But then What do you think these kind of candidates should be doing to improve their profile till the time they match or till the time they even apply for the next year's match? Do you have any tips and suggestions for these candidates to make their profile a little bit more stronger? So at least for the second time or the third time, they have a chance.
So I'm going to be a little harsh here in this thing, because I think this is a safe space to be harsh. Uh, None of the people here have turned on their camera. None of the people have turned on their mic if or spoken or done. I mean, they might be muted right now, but that is basically the problem. We, as a 25, 24-year-old graduate from India, are very good students. We are quiet. There's a cultural difference here, that there is an order, okay, that we have to be subservient to the faculty. But think about a 24-year, 25-year-old guy who's an engineer in America. Okay. They're already done two, three startups. They've already bought a house. They're buying the second house. So that's the big discordant, right? One of them is behaving like a 12-year-old teenager, and another one is behaving like a 40, 50-year-old like middle career person. So even if you get 15 interviews, unless you can bridge that gap, you will not be able to maximize it. Because on all the 15 interviews, you were shy, you were meek, you were not being able to demonstrate your passion, your intellect, your interest. And I think the best thing to do is a year before the interview. Go to a million conferences, shake hands, get away your nervous jitters, talk to the program director, associate program directors. Again, it's expensive to travel from around the world to America, but Zoom does not work. Okay. Even in the past, people like when I did my interviews 2008 for 3 months, I stayed here for the interview season, hoping that I would get a lot of interviews.
I do agree. And that,
Yeah, but every weekend, like email 100 people, Mondays, Tuesdays, try to go and meet people, go to conferences, and just shake hands. They'll say no. What happens to you?
right. Um, Now, I have some questions which students have already posted in the past. They wanted me to ask you. So first of all, what do program directors look forward for an from an IMG, especially for those aspirants who are looking forward for surgery only?
Yeah. I mean,
I guess it's
surgery
your
is fun.
forte. It's your
Yeah.
forte.
I mean, I will tell you whatever I tell all my med students who come through here. Surgery is fun, but the ROIs, return of investment, is very poor. Yes, we make a lot of money, but the delay in gratification, the sacrifice that your body, your family takes is just not worth it. Okay. If this is a passion project of yours, if this is an itch that you need to itch, it's a great itch. Okay. You will get a lot of adrenaline, dopamine, and all those kinds of things. And it's fun. It's fun to work as a team, taking care of complex patients. I have operated the last 3 days of this week and in three different pathologies, big cases. All of them could be a video recording in a conference. Um, but it's hard. So if you want to do surgery, definitely try. It's a very gratifying field, but you have to be aggressive. You have to hustle. You have to go and meet everybody. And maybe out of 100 handshake, one of them will give you an observation. Out of 100 observations, maybe one of you will get a interview. Okay, the competition is hard, but I have seen so many successes and I remember the successes, but I have had multiple personal failures and I've seen multiple failures. But you just have to move on. There are prelim interns under us whom we wanted to keep, but because of visa issue, they had to go back to their home country. Okay. So I know that the they are good surgeons with a good heart, but they just could not finish the residency. So it's tough. Lots of people switch and go into medicine, gastroenterology, cardiology, and they do immensely well. Okay, and they remember their old times as a surgical resident, but I think they are happier than me. So try for surgery, it's hard, but if you try, you might succeed. If you don't try, you'll always have a regret in your heart.
Great. Um, so moving on to the next question, sir. We have many students here asking for, at a 240 score, should I go ahead with a USMLE or should I quit the dream of US residency?
That's up to you. That's completely up to the person. Means I was mentoring probably 20, 30 med students, American med students, but not from our Ivy League schools. And bunch of them had multiple abstracts out, but their scores were 240 or lower. And they quickly pivoted to dual applications, surgery and others. And they got physical medicine and rehab and all those things, and they're very happy. Okay. Or uh, and I am happy that they tried, and because their scores were little low, they were practical, they dual applied, and they were able to get into a residency program, and they can go on with their life. To persevere with a bad resume is stupid. Okay. You need to learn how to pivot. If you're stuck on one thing, it's okay, but take criticism and keep moving on. Every year you delay joining residency is a year lost in earning money. Average salary of a general surgeon today is $500,000. You might not think of it right now that, okay, I'm going to spend 1 year of my parents' money, but that means your family will make $500,000 less. I just don't think it's worth it. Surgery is worth $500,000.
I'm pretty sure students now must be, confused state. What am I supposed to do next? But I'm pretty
So,
sure.
yeah, so if you get a poor score, build up your other points, apply and apply widely. Don't wrap up with the scores of less than 240, international medical graduates, no papers. Don't apply for neurosurgery.
Correct.
Okay. Apply to some surgical branches, but some non-surgical branches, some non-competitive places. Find out which programs have taken people with 240s before from your medical school. There's a huge, you can't, this is very different from like Indian, you just get a good score and go from a ranking process. This is not a ranking process. This is a matching process. So unless you know where people have got in with your CV, it's very hard to figure it out.
Yeah, I mean, even I do, keep suggesting students that if you're looking forward for a surgical branch, don't be, adamant that I want surgery only. I mean, no one owes us that seat, but you have to earn that seat. So always have a plan B that if I do not get into surgery, you spent in years to, do your USMLEs, USCs, research, publication. You've come till this stage and you've got a 240. But if you do not get a surgery, at least other fields like maybe medicine, pediatrics, psychiatry, or anything which suits you is open for you. So even I'd like to just add from my side that don't just be hell bent that I want surgery only. I'm pretty sure, guys, you'll be left with nowhere, neither India nor US nor surgery. So have a plan B at least with you is certainly one of the things that I would want. So tell me one thing. Many students do ask me that the journal in which the research are published, does that really matter a lot? That it has to be Scopus, PubMed, or something, or any good journal is equally fine for application for the residency?
Uh, I would say start. Don't think about those things. I'll give you a personal innuendo. Uh, a Middle Eastern student studying in Western Europe was doing an observership with me, and I suggested, and he wanted to do surgery. Okay, um, and I said, okay, let's write an abstract. But he did not want to write an abstract. He wanted to write a first author paper in Nature. I was like, nobody can get a first authorship paper that gets published in such a high prestigious journal. So don't do research um, to get authorship or get into a fellowship. Start reading, start writing. Today, there are so many technological skill sets. You have the same amount of access as a Harvard professor. Okay. Start reading and writing, learn the art of these things. There are so many free online courses. Start with a simple abstract, 4 paragraphs with some 3, 4 pictures. If it is a surgical case report, go to a local conference, publish it to a local Indian community journal, then to a national journal, then to an international journal. Try to get small grants for few 100,000 rupees or dollars. Okay, then go for the bigger ones. Nobody expects you to have a PubMed index article as a first author while you're in medical school. Nobody. And if you are writing papers that is getting published in PubMed or Nature and stuff like that, 95% of the programs are out of your reach, or they will think that they are out of your reach because you are a PhD scientist. So start small and go to conferences and try to publish all those things. My publications during residency was minimal.
Okay. Thank you so much for that insight, sir. Now, I'd like to, repeat the same question which we've covered earlier, but this time from a different perspective or an angle. Again, the same questions are popping up, so I know I'm forced to, take the same question again, but from a statistical point of view, like what is the minimum prerequisite that as a program director you would want if you were like, sitting in that seat at this point in time? What would you expect the student's profile to be, which defines like an impressive profile, which includes what CK scores would you personally prefer? How many research publications and LORs and clinical rotations would you you personally prefer? I know it's a very vague thing because different program directors would have different perspectives to look at a particular application, and I always tell the students that it's not like a checklist that if you have five that the seat is yours, and if you don't have two then you don't. It's not that ways, but we'd like to know your perspective as a program director.
So my perspective as a program director, I go for those five pillars, right? It's a holistic thing. Okay, like professionally, we try to look at the 5 pillars: clinically good, can do administrative tasks, can do some kind of research, can educate or teach the next generation, and surgical skill sets. These things should come out in the CV. Okay. They do not need to be like 10 first authors. Okay. Something. And if it is in your CV, you should be able to talk about it. In the interview, I was like, oh, your your paper on the eating too many chewing gums causes pancreatic cancer is interesting. Can you tell me how did you find it out? And I said, oh, doctor, I was just collecting data for the my advisor. That basically means that your CV is completely false. Okay. So, whereas if somebody's like, doc, I got this idea because I saw this paper and then I did a research on PubMed. I got all these articles, took it to my advisor. He said, like, okay, let's do a randomized study of 20 people. I'm like making up the scenario, right? That I give 20 of my colleagues chewing gums and 20 of my colleagues placebo chewing gum. We wrote an IRB. And do you know that all the students who ate chewing gum got pancreatic cancer by the time they graduated, and the p-value was less than 0.05. That is the passion and enthusiasm. Okay, in that thing, I could figure out that patient has everything we need. He's clinically good. He can do administration, created all these things. He can do research. The way he sounds, he can probably get consents, teach. He can work as an independent person. Again, in those 5 years, we can teach the guy how to operate. We can teach the guy how to differentiate between diverticulitis and appendicitis and perforated this or that. But that interested enthusiasm complete package is what we're looking for in the CV, which is very hard. So try to see that you get above average scores. Okay, some people do, again, those scores change every year, so there's no hard number. 235 is the usual cutoff, 240 is the good cutoff. If you go to an Ivy League, they'll go for 260s and above. If you go to neurosurgery, probably even higher. But there are a lot of 270s that we don't interview because that's not a good match for a community university affiliated program. We want somebody to have some kind of research, has gone to a conference. So we are not looking for first authors at Nature, but at least 3, 4 lines that then gone to a local conference. In the interview, we can talk about their papers, their interest in those things. If you have 40 first author publications, you're probably not a good fit for us. Um, Clinical rotations and observations is important, especially if one of your letter writers is an American who states that I've seen this person, again, used in first name, that I've seen, I'm taking Harshika, uh, interact with my colleagues, my staff, my patients, and Harshika is a good human being who can interact without getting. And but if you say, oh, Dr. Reddy came and spent 30 days with us from this day to this day and was very impressive, full stop. That's not a letter of recommendation. So I think US clinical experience observerships in which the letter sounds that they personally know you and vouch for you being a normal human being is very important.
Thank you so much for the insight, sir. I know you have some, patients lined up in a short while, so we'll just, get towards the, conclusion of this particular session. We'll just have last couple of questions before we wind up. I have one specific question from a student who's saying, I'm a cardiothoracic surgeon and I'm looking forward to take a fellowship in the US. And what are my options? And do I still need to clear all of my USMLE exam?
So if you want to touch a patient, you will have to give your US clinical exams. Okay, because here you cannot, uh, yeah, so to enter an operating room, you need malpractice insurance, even as a medical student. Nobody will give you malpractice insurance if you do not give your USMLEs. Okay. There were other ways to get malpractice insurance. Today, the world has become very corporatized, very difficult. I think the best way for you to get a fellowship would be through your surgical associations. Know 100 cardiac surgeons, talk to them, interact with them. A lot of these programs have exchange programs, funding that you come and do an observerships. I know that a lot of Indian neurology, neurosurgery people, even cardiac, they come and do a fellowship, which are more borderline research slash um, observership. But because of those things, people gain a lot of experience, might not be hand-on experience, and but then they go home and they are better than their peers. So I think best would be to go through the national and international cardiac surgical associations. Make those connections, see who can vouch for you, who's taking you people. Because say the chairman of neurosurgery at AIMS and the chairman of neurosurgery at Yale probably know each other. And if there is a funding for an exchange student, maybe you can get it.
Great. Um, I have one question. I'm pretty sure all the students, listening here must be waiting for this question, or they would like to, get an answer from you. What do you think? I mean, since so many years, or more than a decade or two that you've been, doing this. You're in the US. You have interviewed personally hundreds and thousands of candidates and applicants, for your residency program and things like that. What tips would you like to give to the students who are appearing for the interview, and on the day of the interview, what are certain tips, do's and don'ts that you would want to give the audience?
Smile, sleep well, bright room, and talk. Talk as if you are a surgeon, not like you are begging for a surgical residency. Okay. We don't want, again, this is not for surgery, this is for anything. Don't be like a scared cat kind of mentality. Again, don't be arrogant and obnoxious, but be confident, be calm, be smiling. Don't complain that IMGs don't get their due share. Um, Show that it's a bilateral relationship. They will learn from you, you will learn from them. One of my surgical residents who was trained in India left surgery and joined family practice because he wanted more personal time. And he said, like, okay, I can develop your vasectomy clinic. Okay. So it was a great, like, okay. So for the family practice program director was super happy with him. Okay. So I do think it's a bilateral relationship. So be calm, be confident. Again, going on the matrimonial thing, it's like your first date. So don't complain too much.
Okay. Fair enough, sir. I guess we've covered most of it. Finally, what is one key piece of advice you would want to give all the aspiring students aiming to match successfully?